we talked about the 50-50 chance that this patient's going to respond to steroids. And perhaps at this point, it's a good time for me to walk us through our next case, which has a slightly different outcome. So the second case is of a 52-year-old who had high-risk MDS with very complex cytogenetics and a very adverse molecular profile, including a p53 mutation. She underwent a matched unrelated donor transplant using high-dose busulfan-based conditioning, and her post-transplant GVHD immunosuppression was with the post-transplant cyclophosphamide regimen. On day 45, she presented with grade 3 graft-versus-host disease, including a skin rash covering 2/3 of her body and more intensive GI involvement with 7 to 9 episodes of watery diarrhea a day that had developed rather rapidly over the course of a week. She also received 2 milligrams per kilogram of methylprednisolone, so given parenterally here rather than orally given the diarrhea, along with her ongoing calcineurin inhibitor. In this regimen, mycophenolate, when it's administered, is generally stopped around day 30 to 35 after transplant, so that had already stopped. But 7 days after starting steroid therapy, she developed 5 bloody stools and much more abdominal pain. And so in this scenario, after 7 days of corticosteroids and the appearance of what would be called stage 4 GI involvement with severe abdominal pain and bloody diarrhea, she has now met the definitions for steroid refractory disease. And so the things that we'll talk about around this case are how do we determine when a patient is in fact steroid refractory, when do you make the move to a second-line agent, what are the triggers, is it better to wait sooner rather than later? And we'll touch briefly on the multidisciplinary approach to steroid refractory acute GVHD management.